Hey everyone, this is a voiceover for the burns lecture since we did not get to it in class, and I just wanted to let you have an overview of this lecture. The major portions of the burn lecture are going to be involved in identifying and sizing the burns. That's the first section, doing first, second, third degree burns and sizing them. And then we're going to be talking about the major burn complications from the major burns. So first I'm just going to point out to you the differences in the skin, and I don't know if you can kind of see, the epidermis will be our, this is where, when we're talking about damage, the epidermis is your topmost layer here, and then the dermis is the one that contains a lot of blood vessels, our skin, hair follicles, fatty tissue, sweat glands, tons of stuff in the dermis here, which is the second layer. So we have our first layer, then we have our second layer, and then the third layer at the very bottom is fatty tissue, mostly fat and smooth muscle and blood vessels, again in the third layer there. So we have our epidermis, our dermis, and our hypodermis. So when we are burned, we are looking at basically the depth there. The first degree is superficial, the epidermis only, the very top layers of our skin, epidermis only. Second degree does go down into the dermis, can affect the skin, nerves, cells that are in there. Third degree full thickness goes down into the blood vessels and down into the hypodermis layer, and in fact can go all the way to muscle and bone, which would be considered fourth degree, but we're not really going to quibble over third and fourth degree. Both are bad. So the muscle and bone tissue there would be fourth degree. All three skin layers is third degree. But that is a technicality. Again, all third degree, fourth degree, all bad. We're going to be looking at the rule of nines. I will need you to know the rule of nines. I will give you, and I have an example a little further on why this is important. We use this to figure out the math. And this will be probably some of the math on your exam will be Parkland formula or burn math. So we use this quick rule of nines as a way to estimate our burn surface area, and you will be applying this. So it's very easy to remember. The large portions of our body count for 18. So the front of our chest, the back of our chest, 18, or the front chest and torso is 18. The back is 18. The long legs of the human are 18. The arms are shorter and are 9, the head is 9, and the genitals are 1. When we're talking about the arms and the legs, usually with heat and thermal injuries, you're just getting splashed to the front, so we will tell you whether the front of the arm is affected, the back of the arm, or the circumferential entire arm. Same with the leg. We will tell you front of the leg, back of the leg, or circumferential, all of it. So I will show you how to use the rule of nines for math in a little bit. The London-Browder method is a more specific, accurate way, but it's a much more complicated sheet, and you'll be trained to do that if you're in a burn unit or in an ED. The London-Browder method is up here in the top corner of this slide. A little bit of the difference, major burn, just the classifications. Again, I'm not going to probably test you on these criteria, but they're good to know for if you're ever working in an ED, because this will determine whether they're going home, whether they're getting admitted, or whether they're being transferred. A minor burn is any first degree or superficial burn. Doesn't matter if it's your whole entire body. First degree is a minor burn. A less than 25% of a second degree, and TBSA means total body surface area. So again, that was on your size here. Total body surface area is TBSA. So if you see TBSA anywhere involving a burn, it means total body surface area. So less than 25% of second-degree burn is considered a minor burn, and 25% is still a large portion of your body. It could be an entire leg and the front half of an arm. It could be the chest and half of an arm. Still quite a bit, but if it's second-degree burn or less, it's still a minor burn, and less than 5% of a third-degree burn. Major burns, of course, are anything greater than 25% second-degree burn or anything greater than 5% third-degree burn. And this is important because any major burns are going to be transferred to a regional burn center. Our burn center, in case you don't know, is at Maricopa Medical Center, which is now Valley-Wise, but Maricopa Medical Center is our burn unit, and I do have a link there if you want to see their little ad about what their burn unit is like. So all major burns will be transferred to a regional burn center. Any burns involving hands, feet, face, joints, or genitals, areas that are high risk for having PT-OT problems and probably needing plastic surgery, will be transferred to a regional burn center. Any electrical injury, including high voltage electrical or lightning injuries, and any burns with traumas, and also inhalation injuries. So those will be transferred. Again, not testable. Good to know, though, if you're interested in ED or burns. The big part for you for the exams is being able to classify them. So first-degree burns are superficial, involve only the epidermis. And how do you know if they only involve the epidermis? They have no depth or blisters. Okay, blisters moves you to second degree. So if your burn is just a superficial discoloration, redness, swelling, and yes, they are painful, there is an inflammation response going on that causes redness and swelling and pain, but it is a first-degree burn as long as there are no blisters. There's no real chance for infection unless the skin is further damaged by itching, and if blisters do form, then it is considered a second-degree burn. But we're going to keep an eye on the size of it, and again, a small patch of skin. You can take a percentage of the arm. If the front of the arm is 4.5 and you have a small patch, you can say it's a 0.5 degree or 0.5% or 1%. Size the burn, pain level. It's going to be extensive, and if there's any drainage or signs of infection, that is a worsening cue. For a first-degree burn, it is just typical burn treatment. There is no heals without intervention in 2 to 7 days. If you've ever had a sunburn, you live in Arizona, I can't imagine you haven't had a sunburn. If you ever had a sunburn, you've taken care of a first-degree burn. Pain relief, decreased swelling, acetaminophen, nonsteroidal anti-inflammatories, oral fluids, a lot of fluids, loose clothing. Don't ever place ice or heat on burned skin. So if there's ever a test question saying put an ice pack on it, do not ever put ice or heat on burned skin. No matter how burned you are, your skin is super sensitive, probably a little bit dysfunctional in sensation. We do not place ice or heat ever on burned skin. Run it under cool running water, but not ice. You can use lotions on unbroken skin to keep the skin moist, but if it's broken skin, it's a risk of infection, and then you would treat it as if it's a high risk of infection. You don't need a dressing, or you can use a dry dressing loosely wrapped over any first-degree burn. Never, ever tape on a burned skin. So no ice, no heat, no tape on burned skin. Kind of self-explanatory. We've all taken care of a first-degree burn somewhere in our lives. Second-degree burns, again, probably most of the population has had some degree of second-degree burns. Stove burns are usually second-degree burns. It's high heat. It involves the epidermis and the top layer of the dermis, and this one does come with some swelling and some drainage and blistering. The second-degree burn has redness and swelling, but also has blisters and edema, and it's usually extremely painful, sensitive to air. Blistering on a second-degree burn, you're supposed to leave it alone. You're not supposed to pop the blister. If they do pop the blister, it should be popped with a sterile needle and just a little puncture hole so that the blister can drain, but that the blister stays intact on top to protect the skin as it heals. Again, we usually counsel people not to touch the blisters on a burn. Let them, they're there. It's protective, it's serous, it's inflammatory drainage. It is fine to stay there, and as long as it's not open or infected at all, it shouldn't get infected, and it will actually cushion the burned skin and the sensitive dermis from the air and having increased pain. But if the blister pops, or if the blister gets popped somehow, then you will take care and do infection control precautions on the blister. This little foot in the picture there is a mix of first and second degree burn. We classify burns based on the deepest depth, so that foot would be considered a second degree burn, even though it's mixed with first and second degree. So if there's greater than 25% of second degree burns, it's considered a worsening cue if it gets infection or if you are getting scar formation on it. And these can bleed. There are some blood vessels in the dermis, not very many. It shouldn't be bleeding wound, but it can bleed. So just keep an eye for that. Care of the second degree burn is mainly making sure that it does not get infected. It is a dry, sterile gauze if you're going to dress it. Dry, sterile gauze dressing, and that includes a Band-Aid. Band-Aids are dry dressings and they have sterile gauze, but it says no tape over burned skin. So on this foot, if you have a tiny fingertip burn from the stove, that can be bandaged, but otherwise you'd probably want to get some sterile gauze, loosely wrap on there, and it's dry gauze because this is going to be a weeping wound if it opens, and you'd want something to absorb that serous drainage. If there is openings or a risk of infection, if the blister pops, you can add antibiotic ointment to your dressing to keep any infection. Keep it clean, and keep it dry, and keep the dressing on it dry, and let it and change it as it gets wet. Again, all the other dressing, all the other first degree care is the same. Pain relief, oral fluids, loose clothing, no ice, no heat, no tape, and you can use lotions on the unbroken portion of the skin. Third degree burns are much bigger deal. They include all layers of the skin. It can involve the tendons or the bone, and the difference between a second and a third degree burn, well, not only is the depth and the appearance of it. The appearance of it is that you could have any version: pale white, charred skin, dark red skin, brown and leathery skin that is scarred, eschar tissue. It's dead tissue. The hand up there is such a beautiful picture, but it is a perfect picture of a third degree burn. You can see how deep and how white it is. A lot of pale white and with scarred, charred skin on the inside. And like I said, you can see muscle and bone through it sometimes too if it is deep enough, and that's fourth degree. The important thing is that these burns are not as painful. The areas of third degree are painless because the nerve tissues has been damaged through the dermis. The nerves are actually been burned away. And the areas of second degree or lighter, of not as deep, would be painful. So it's a mix of pain and painless, but a third degree burn can be painless. And that's not a good sign. It's a sign that your nerves have been burned away. When I was working in the burn unit, we had a patient came in and he goes, "Oh, I'm not having any pain, so my legs are doing okay." And we're like, "No, your legs are not doing okay." He was massively third degree burned, but he couldn't feel the burn because the nerves had been burned away. So can be painless, which is good for them. But it's also extremely painful if there are some nerve endings free. So there's not really, the areas of deep third degree are painless, but not necessarily completely painless, because Most third-degree wounds have second degrees and first degree around it. So anyway, the worsening cues on this one is definitely infection. There are also complications of major burns, and remember, the minor burn of a third degree is only less than 5%. That's a very tiny burn in terms of your body percentage, 5% or less. Anything over 5% is going to be a major burn, and we're talking about major burns in a few slides. But for an isolated, small, minor third-degree burn, now this would be a major burn because it involves the hand, the picture that we have up in the corner. That would be a major burn because it is a hand. Hands, feet, joints, and genitals are considered major burns. But anyway, for a small or a minor, less than 1% burn, you can do home treatment of less than 5% with no involvement of hands, feet, face, joints, or genitals. So if you end up with a patch of third-degree burn on your arm, it can be treated at home, but the burn center will treat anything over than 5%. The treatment, if you do treat at home, is a sterile dry dressing saturated with antimicrobial cream. So there will be a prescribed cream that is an antibiotic that you impregnate on that dressing. So you would put the cream on the dressing and then dress the wound over that. The bandages would be changed once or twice daily with the full clean with soap and water in between, and possibly outpatient skin grafting for third-degree burns do not heal well. So even a small piece of and probably the most common, it's not really a third-degree burn, but a full thickness injury would be if they remove a piece for a melanoma. Some of those require skin grafting as well. Third-degree burns do not heal well because there's not a good wound bed left to granulate tissue on. So it would be probably sterile dressings with antimicrobial cream, change them once, twice a day, keep them clean in between, and pain relief for the areas that do have nerve sensation. Skin grafts are possible on third-degree burns that are not healing. So we're just looking at the different causes of burns here. Any of these can cause first, second, or third-degree burns: heat, radiation, chemicals, electrical. I'm just going to point out radiation burns are usually first or second degree, and they're usually for patients with getting chemotherapy/radiation. Can be first or second degree burns, and the length of exposure and the dose affects the severity. So the longer the dose, the more you're exposed. Those end up with the wet weeping radiation burns, and you would treat those like a second-degree burn with a dry gauze lotion on unopened portions of skin. Chemical burns, again, going with the ED lecture, and toxins is we want to irrigate or remove the toxin from the skin. Here it is a chemical. Both acids and alkaline products can cause burns. Anything below or above the normal skin pH can burn the skin. Acid products, of course, are acidic and they burn and they hurt, and they're irrigated off pretty quickly. Alkaline products such as chlorine and lime and cement are alkaline products, and they actually, people don't notice them on their skin. So alkaline burns usually are more severe because the alkaline product sits on the skin longer before it gets irrigated, and can cause more damage. But the full extent of the injury on a chemical burn can take up to 72 hours. So even if you irrigate it off, if the skin has been burned, sometimes it takes a while. You know how they say it takes some time for a burn to develop? You get sunburned on the first day, or you don't think you're sunburned on the first day, and the second day you wake up. Burns will continue to evolve over the first 24-48 hours. So heat and radiation burns, they will evolve over 24-48 hours. Chemical burns, though, they evolve over a little bit longer. It can take up to 3 days for the full extent of the burn to show up. Electrical burns, what I'm going to point out on electrical burns is to try and find out the number of voltages and look for the entry and exit wounds. Electricity flows through the body to the ground. So if someone is holding an electrical wire, or if you poke your finger through an electrical socket, the energy doesn't just stay in that one area. electricity travels through your body and out to the ground. So the patient with the hand there at the circle, this the one at the very bottom, that is an electrical burn, probably from someone holding on or grabbing onto a high voltage wire. Where that energy enters the body is the entry point. There's always an exit point. It's probably where they were, if they were standing somewhere near the feet, wherever that it leaves the body. And so we want to look for the entry and exit wounds, because then we know the path of the electricity and all the stuff that will be damaged along the way. So when you have high voltage electricity, whether it's touching copper wire, which is where a lot of these patients will come in from, they're trying to steal copper wire out of high voltage electricity. They will get these copper wire burns, and they're usually around the hands with exits around the feet. Or if they were holding on to something and they were grounding with the other hand, then the entry is the hand they were holding the wire, and the exit could be the other hand that was holding on to something. But what we're looking for is the path of electricity, because as electricity goes through the heart, you may go through the body. It may there's a high risk that it hit the heart somewhere along the line, and there is extensive burns internally from entry to exit wounds. So always with electrical wounds, high voltage electricals, look for, and this is really for high voltage. I mean, sticking your finger in a socket of the wall, that's not as high voltage as high voltage wires out in electrical transformers and whatnot. But anytime someone has a high voltage electrical wound, look for an entry or an exit and assume internal injuries from that whole path. And most of these patients get an EKG monitor because electrical burns do affect the heart. So that's kind of quick care of first, second, and third degree burns, easy, the smaller minor burns. Then we go into major burn management. Again, this is greater than 25% of a second degree burn or greater than 5% of a third degree burn. We have a whole series of complications. Now, they're all kind of, I don't want to say they're all expected, but it depends on where the burn is, whether they are expected or not. With a major burn, they are complications, but they are expected complications. If you are burned up in your airway, then we expect airway compromise. We expect respiratory failure. Large major burns, we expect hypovolemia, not all the way to shock. We expect pain. We try to prevent infection. We expect these things. We try to prevent them the best we can. And that's what we're going to go through in these next few slides. So for a major burn that is at a major burn center, what I'm going to point out to you are the complications, how we recognize them, and what we're doing to either prevent them or treat them. Airway compromise is any facial burn. It doesn't matter if it's first degree, second degree, third degree, any facial burns, any exposure, which means that you are actually breathing in the high degrees of fires without protection, exposure to high degree fires, any singed nose or eyebrow hairs, soot around the mouth, nose, hair, face, coughing up dark sputum, hoarseness, painful swallowing. All those things are cues that your airway has been burned. Now, the picture on the top here and the picture on the bottom is the same patient 4 hours at arrival and 4 hours later. So you can see the patient at the beginning there does not have a breathing tube in, but has visible facial burns. And you're like, oh, they're only first degree. This patient looks like he's first degree burns. But facial burns, he has singed his eyebrow hairs away. He has no more eyebrows and does not have soot around the mouth of the nose, but any cue is giving you airway compromise. Even though he has what looks like first degree facial burns, the fact that he has singed eyebrows hairs means that heat that that person was exposed to was high enough to singe hair. And if it's high enough to singe hair away, it is high enough to damage the airway. The problem that you have with a swollen, damaged airway is it's going to swell and it's going to close up. So we intubate inhalation injuries. So any airway compromise, any facial burns, any singed eyebrow hairs, any soot around the mouth, nose hair, coughing up sputum, we are assuming an inhalation injury and they will be intubated. It's very easy to extubate the patient if they do not develop airway swelling. You can extubate them the next day and say, well, we thought you might swell, but you didn't, so we're taking your tube out. Because edema happens from the time of the burn up to 3 days after the burn, these patients will be intubated, and it's better to intubate while they are not swollen, but until trying to get that tube in after they're swollen is impossible. So this patient was going to buy a tube right away, even if they're not in respiratory failure. And that's an important key cue. We can have patients that are talking and feel fine, maybe just have a little bit of hoarseness, but they're satin brate. They're still going to get a intubation because we're anticipating the swelling of the airway. So intubate inhalation injuries before any worsening cues. We're not waiting for respiratory failure. We're not waiting for them to start complaining of stridor. We are too late at that point. The swelling has already happened and it's going to be hard to pass in the tube. So if you see singed nose, eyebrow hairs, any facial burns, or report that they came from a high degree fire like a car fire or a house fire, and you suspect an airway compromise, they will intubate sooner rather than later. The other problem is later on respiratory failure. Massive inflammatory response happens after every major burn. A lot of burn patients end up with pulmonary edema and ARDS due to a massive inflammatory response, capillary leaking to the lungs. Airway burns or smoke inhalation can cause carbon monoxide poisoning. And this is where if you're exposed to carbon monoxide is in smoke and in toxins from fires. If you breathe in carbon monoxide, it attaches to your hemoglobin molecules and does what up at the top here, I love this little personification. Hemoglobin holds 4 molecules of oxygen. Most hemoglobins hold, hold 4 little oxygens here. I'm trying to draw. So here's our happy little hemoglobins. That's because it's too close to my arrow that moves the slide forward. So anyway, holds 4 oxygens. So we're like, that is a great hemoglobin. When carbon monoxide enters your body and you inhale it, carbon monoxide attaches to your hemoglobin molecule and makes a carboxyhemoglobin. But this one only holds 2 molecules. So once carbon monoxide comes in and attaches to your hemoglobin, it's now called a carboxyhemoglobin molecule. It changes your hemoglobin molecule. And now it can only carry 2 oxygens. So the problem with carbon monoxide poisoning is that you actually read you're 100% saturated, because you are. Carboxyhemoglobin carries 2. It's holding 2. It's 100% saturated with oxygen, but it's only carrying half the amount that we are supposed to be carrying around. So you can end up with hypoxia and 100% saturations. And that's the danger of carbon monoxide poisoning. Circumferential eschar, so in a full thickness front and back burn, that patient in the bottom, I'm sorry if it's disgusting and you don't like looking at it, but this is basically a patient whose skin has gotten so leathery and burned through that they can't inhale or exhale well. Their skin has burned to a tight glove around their chest, and so the treatment for that restriction of inspiration is to actually cut through the burned tissue down to the muscle layer. And yeah, that's a very graphic photo. Sorry about that. But with respiratory failure that's happening, this again, pulmonary edema, ARDS, carbon monoxide, those things are happening over a couple of days, and we are going to be watching out for hypoxic signs and symptoms. So headache, dizziness, dyspnea, all the hypoxic signs and symptoms we learned about in respiratory failure. The other thing that we will watch with patients with any kind of upper airway inhalation injury is a carboxyhemoglobin level. We should not, if you have inhaled carbon monoxide, you will have an increase in your number of carboxyhemoglobins. So any carboxyhemoglobin level greater than 20 is considered carbon monoxide toxicity. So if we have that, then you're going to get 100% O2 regardless of your oxygen saturation. You're going to try and oversaturate your hemoglobins and get that carrying around. BiPAP and CPAP if we need extra ventilator support, mechanical ventilations, and that's about it. So the treatment for carbon monoxide exposure is 100% O2 regardless of what you are saturating. Hypovolemia, hypovolemic shock. We're trying to avoid hypovolemic shock. Burns, leak, burns, swell. It's what they do. You end up having massive amounts of what we call insensible or immeasurable losses, drainage from the burn wounds, and just leaky capillaries. Also, this massive, a major burn causes a massive inflammatory response, of course, to the entire area that is burning. And so all that inflammatory tissue is just leaking out of the burned area. Tachycardia, hypotension. Again, when we talked about our shock, we talk about compensatory and then progressive phases. We don't want to wait till they're hypotensive to treat them. As soon as we see a major burn, they're going to be treated with fluid because the replacement for hypovolemia is fluid replacement. They are not necessarily bleeding. This is inflammatory serous drainage, and we want to replace it with regular fluid volume. We replace it with lactated ringers. And there is a specific formula for the first 24 hours of fluid replacement for any major burn, greater than 25% second degree, greater than 5% third degree. Any major burn is going to get Parkland formula resuscitation, and that is the patient's weight times the body surface area burned times 4. And we give 50% of that fluid in the first 8 hours and 50% in the next 16 hours. So this is going to be your math questions that you have on there. Not all the math questions, but a lot of them. For the first 24 hours, we follow Parkland formula for any major burn. 4 times the weight in kilos times the body surface area, which is why you're going to need to know how to use your rule of 9s to figure out total body surface area. After 24 hours, and I have an example on the next slide that we're going to go through. After 24 hours, then we move over to colloids, some thicker fluid that's going to pull fluid from the tissues back into the intravascular space to maintain volume. But in the first 24 hours, when edema and swelling is at its most prevalent, we are just going to replace fluid, and it's going to be a lot of fluid. We're not waiting for our signs and symptoms and vital signs to tell us. We're just going to do it. So here's an example slide that you have a patient that comes into the ER, and this is very similar to the math that you will get on an exam. It has some vital signs there, but I don't care what your vital signs say. We're still going to give the Parkland formula because this patient has a major burn. They have partial thickness, which is second-degree burns, to the front of the chest and the abdomen and circumferential left leg. So we know that the front of the chest is 18. So the chest and the abdomen is 18, and the circumferential left leg is 18, making it 36% of the body. Partial thickness burns greater than 25% are major burns. This is a major burn, and it's going to get Parkland formula. So we found the front of the chest and the abdomen is 18%. The entire left leg is 18%. Because it's circumferential, it's not just the front and the back, it's the entire leg. So we have 36% body surface area, so we find their weight in kilos. The weight in the question is different than the weight in the answer. I wanted to make it something that was even, which I usually try to do for the test. So he's 176 pounds because it worked into even kilos. I love even kilos, not point something kilos. So he's 176 pounds, and he's 80 kilos. So we do 4 times 80 times 36 to figure out our total 24-hour volume. And our total 24-hour volume is 11,520. We give the first half of that in the 8 hours, which means we are going to give over almost 6 liters of fluid in 8 hours. Yes, we are. We are going to throw that fluid in. So be sure that you read your question on the test. So this is how much fluid will Mr. Smith need over 24 hours? We stop right there at 11,520, and that is your answer. Now I can ask you how much fluid you give in the first 8 hours. The answer to that one would be 5,760. How much fluid do I give over the next 16 hours? 5,760. I can also ask you, what rate do you set your pump for the first 8 hours? To give 5,760 over 8 hours, you're going to put your pump at 720 milliliters an hour. So please be sure to go through the math questions that I put in your module. Under supplemental material, there is Parkland math questions and Parkland math answer key. So read the question and find out, am I asking you how much fluid do they need over 24 hours? Am I asking you how much fluid they need over the first 8 hours? Am I asking you how much fluid they need over the second 16 hours? Am I asking you, are you putting a rate on the pump? All those will give you different answers. If I ask you, Mrs. Smith, how much fluid will they need over the second 16 hours? The correct answer is 5,760. If I ask you, what are you going to set the pump at for the second 16 hours? Then your correct answer is 360, because we know we have to give 5,760 over 16 hours. We're running it at 360 milliliters an hour. So work through those math problems. The math is easy, 4 times kilos times body surface area. But you're going to need to be able to be comfortable. I'm not going to give you the Parkland formula. I'm not going to give you the total body surface area map. So get kind of comfortable with doing the total body surface area, because I will give you a question, just like at the top there, where I'm going to tell you what is burned, and you will have to figure out the total body surface area. The math itself, very easy, 4 times kilo times total body surface area. The hard part is reading the question and getting the correct answer. And so I'm just going to ask you to always read the end of the question and make sure that you're answering with the correct answer. Am I asking for total fluid? Am I asking for milliliters an hour on the pump? And figure out the correct what I'm asking. So I have a whole bunch of math for you on the Parkland math worksheet. For pain, we expect them to have pain. If they have a large major burn, there's going to be areas of mixed, second, third degree, first degree, second degree. Second degree is extremely painful. First degree is painful. Third degree with nerve endings remaining are painful. So analgesics, don't wait for them to have pain. Analgesics early and frequently. PCA is the best way to manage burn pain. Narcotics provide the best relief, and will supplement them with non-pharmacological, but they're going to get a lot of narcotics for pain relief. A good technique is potentiating your narcotics with your benzodiazepines. If you give them an anti-anxiety along with narcotics, they potentiate each other. You can do lower both doses of both kinds. So that works out pretty well. Maybe a morphine PCA with a PRN Ativan. Medicine should be administered IV or PO, no IMs, no sub-Qs. Your burn, even if it's into a non-burned area, we do not do IM or sub-Q injections in burn patients. They don't absorb. Their skin is in stress, there's a lot of vasodilation, there's a lot of leakage and seepage of wounds, it's better to put it IV or PO if they're still taking PO. We are unable to remove the pain entirely. Let them know that their pain level will not be a 0. They have been burned. We cannot anesthetize you out of your burn. So we won't be able to remove pain entirely, but work with them on getting an acceptable level of pain. Again, most patients want to be put out if they have a major burn. That's not usually done after the first few days of a burn therapy, because we need you to be involved in physical therapy around your burn. So unable to remove it entirely, but make sure you are monitoring their acceptable level of pain during their burn. But pain is important to manage, and don't be afraid to give them what they need, which is narcotics for pain control relief. Infection, of course, is a huge problem. You've lost your first line of defense against infection, which is your skin. As soon as you have open skin, you have a high risk of infection, and actually sepsis and multisystem organ failure is the most common cause of death in burn patients. So we're watching all the dressings for any kind of changes in color of the wound dressing, the wound drainage. They are at more risk for infection because they get a lot of invasive lines, artificial airways, Foley catheters, central lines. All this is needed for the high amount of fluid that they're getting, the needs of intake and output. Most major burns have central lines, Foley catheters, and artificial airways. All of them are a risk of infection. So prophylactic antibiotics are important. Protective isolation, all burn units, everyone's gowns, gloves, masks, all the time, even to come visit their family members. Protective isolation, strict hand washing, and it's for the patient's safety. We have to be their skin for them and keep infection out. So the picture at the bottom there is family and staff all talking to a burn patient, and they are all gown, gloved, masked. We're not doing it to protect us from the patient. We're protecting the patient from us, not us from the patient. So it is protective isolation. Prophylactic antibiotics, and also with third-degree burns, we're impregnating their dressings with antibiotics. So they will be getting both topical via their dressings and IV via prophylactic IVs. Renal failure is a major complication. We will try to prevent it with our Parkland formula and our fluid resuscitation. But when you have massive hypoperfusion, the kidney is usually the first one to feel it. Pre-renal failure due to low circulating fluid volume, and also a direct toxicity is from muscle skin breakdown. We create myoglobinuria, so they have a lot of myoglobin breaking down from these burn sites, and that is toxic. The kidneys try to excrete it because myoglobin is toxic. But it does cause intrarenal failure. So they have a pre-renal cause because they have low circulating volume, and they have tubular destruction from the myoglobin and have foamy dark urine. So we're going to try to proactively fix this and keep the kidney functioning for us by large amounts of fluid, which the Parkland formula does provide. Even after the first 24 hours, they're still getting large amounts of fluid to help flush the kidney. So administer fluids, adequate urine output, flush myoglobin, and make sure that you are as intravascularly filled as possible. So renal failure, definitely a complication expected. We try to prevent it. GI bleed, paralytic ileus, again, whenever you're having massive immune response and swelling and decreased perfusion, your GI feels it as well. You're at risk for stress ulcers due to such a major trauma and a lack of perfusion to the GI tract. So usually they will, we try to keep PO. You feed the gut, try to use the gut, or you lose the gut. So unless they have a paralytic ileus where they're not moving at all, we will go ahead and do feedings, either orally or supplemental with an NG tube. Looking for GI bleeds, looking for stress ulcers, do stress ulcer prophylaxis with H2 blockers or proton pump inhibitors. Sulcrofate's kind of a last ditch. It's a coat. It coats the ulcers. We're going to do stress ulcer prophylaxis with proton pump inhibitors or H2 blockers. So we're hoping to see no blood in the stools if we get the stress ulcer prophylaxis in first. And then we're going to be watching bowel sounds, listening for any signs of paralytic ileus or problems with GI function. Swelling burns also can have compartment syndrome as well, and this isn't due to the bone causing problems and causing swelling in the tissues, but the actual burn is trying to swell, and if the skin around it is third degree burned and as eschar tissue, which is thick tissue that doesn't give and doesn't swell, then compartment syndrome is a risk. You'll be doing neurovascular checks on any burned extremity for this compartment syndrome and looking for the 5 Ps, the same as you learned in the bone fracture. We'll be looking for pulselessness, power, pain, paresthesias. What's the 5th P? Paresthesias, pain, power, pulselessness. Sorry, the 5th P is paralysis. Oops, no, go back. I was going to add it in there for you. Paralysis, or not being able to move the extremity. Pulselessness, pallor, pain, paresthesia, and paralysis would be the 5 Ps. So always, just like with, even though there's no broken bone, we know there's swelling going on, and swelling, if it gets into that interior compartment, can cut off blood flow and nerve sensation to the lower extremity. So a lot of burns are elevated to help blood return, decrease swelling, and if the skin, this happens a lot with circumferential burns, end up with compartment syndrome. If the skin around it is so leathery and tight that it cannot allow for swelling, then they will do a fasciotomy, which is where they cut the skin or the remaining burned skin and the tissue all the way through to the muscle fascia to allow circulation to return to those. And I don't remember if you remember the picture of the leg. I'm going to try and draw it there. But if you have the leg, and this is looking down the leg to the foot there. There's my little foot. If you're looking, you have the blood flow, so you have like a compartment here, a compartment here. We have one compartment in the leg, and I do believe in the arm, that the blood flow all flows through these areas in between the muscles. So if we're going to, the blood flow is all flowing down through these areas here, through these fascia that's in between the muscles. And if for some reason it starts to swell, so if we have swelling here on this compartment, if this area starts to swell, it will push up against the, hopefully it swells out to the outside. The skin has some give to it. But if the skin doesn't have any give to it, this swells and actually cuts off the blood flow there in that area and causes the symptoms of compartment syndrome. So again, look at my beautiful little picture. There's little 5 little toes there. That's actually a pretty decent sliced leg that I drew there. But anyway, that's what we're looking for compartment syndrome, is lack of sensation or blood flow to the extremity of a swelling extremity. Your skin is involved in making sure that you stay warm or cool. We have, our hairs rise, we shiver, we do things. Patients with a major burn are at high risk of hypothermia because we can't regulate our temperature. And so they will be doing a lot of warm rooms, hypothermia blankets, fluid warmers. I was a burn tech through college, and all I did was I would go in during the day and we would do dressing changes. And the dressing change rooms, you're in full isolation because you're protective isolating, because you got the patients all down to to nothing and you're about to put dressings on. So, of course, because you are taking down their dressings and you're in full isolation and the room is like 90 degrees and all you do is sweat all day long. But it's for the patients. The patients, when we take their dressings down or when their dressings are on, they're still losing a lot of fluid, and they're evaporatively cooling, and they also don't have skin to regulate the temperature. So warm room temperatures, environments, burn centers are warm, and you are sweating because you're wearing isolation. But make sure they stay warm. Nutrition is huge. Nutritions are basic metabolic rate with this massive amount of damage and healing that's going on is 40 to 100% above your normal rate. So if you normally can sustain yourself on 1,500 calories a day, now you may need 3,000 calories a day. Now you may need 6,000 calories a day. It's a ridiculous amount of calories that you just usually, even if you were eating nonstop steak, you would not be able to meet your calorie requirements. So a lot of times supplemental feeding is necessary. Use Glucerna, Ensure shakes, trying to get people to eat high calorie but good food. The daily caloric intake can be 2 to 20 times their normal caloric recommendation. So you can have a patient that needs 8,000 calories a day to survive, almost like bodybuilder kind of calories, but they're not doing it to build by, they're doing it to heal. So huge amounts of caloric intake, and most patients cannot physically eat that many calories, especially after a major burn. So supplemental feedings are usually necessary for burn patients. So that's your one takeaway from this slide. Supplemental feedings are usually necessary. Then there's the actual wound care yourself. I've tried to keep the gory pictures to a minimum here. So wound care involves debridement and dressing changes. Debridement is the first part, and that is physically cleaning the wound. And so this is my poor kids. I'm going to scrub everything. I did burn debridement as a college tech. That's what I did. It's a great job. It's a great job. If you are a picker, let me tell you, there's nothing better than wound debridement. You know, if you're like one of those people that likes to peel some people's sunburns, or you like to pick at scabs or whatnot, debridement is the place for you. There is nothing more satisfying than cleaning out a wound bed. I'm telling you, maybe wound care nurses can kind of come at me and stand up for me here, but there is nothing better than cleaning out a wound. Burns usually come with clothes charred into them, debris in there, the actual burn charred pieces of skin, flesh. So anyway, that all needs to be kind of cleaned out, and it's done over time. We're not going to go in there and rip everything out of the burns and cause bleeding, but wound debris does slow healing. We need to remove blisters, dead skin, try to get the environment as clean as possible, these wounds as clean as possible, so that they can heal better. It's done mostly using hydrotherapy, which is a daily tanking. It's used during the shower tables now. The shower tables are draped with a sterile field, and the patient's on them and they get showered. It's warm water. That room, I will tell you, is 90 degrees, and the staff is in full, but that room is warm. You use the special tables that drain water away from the patient, because immersion in water, they used to do them in like whirlpool kind of tubs. Immersion in water, it increases infection, so they've gone away from the whirlpool hydrotherapy, and it's usually just shower tables. But basically take down all the dressings, clean everything out of the wound. Just basically you're irrigating with soap and water, not scrubbing. The debridement is done gently with tools, and the physician is there as well to do some debridement. They can do surgical debridement. They can go into surgery, and some burn patients are surgically debrided weekly, just to go into a sterile environment and get the wound debris out of there. You can also put an enzyme in the wound dressing that will assist with removal of dead tissue from the wound bed. So collagenase actually breaks down collagen and proteins. So you break down some of those things that are not helpful in preventing a wound bed. The whole purpose of burn management is to try to get a granulating, meaning a bed of dermis that will grow skin tissue. So the whole point of hydrotherapy enzyme is not only just to keep it clean, but to remove this wound debris that's sitting on the granulating wound bed so that you can create a nice, clean, pink wound that will grow new tissue on it. The dressing changes themselves are usually done once or twice daily. Adequate pre-medication with analgesics, narcotics, sedatives. It is a sterile procedure in a warmed room, and you want to keep that wound as clean as possible. The dressings are usually impregnated with topical wound antibiotics. Sometimes the enzymatic debridement if that is necessary, but usually just some kind of antibiotic. And silver is the most common antibiotic that prevents bacterial growth. You can put bacitracin, gentamicin, xerofoam, iodine. There's lots of different kinds of impregnated gauzes. But what you will do is put down the impregnated gauze over the wound, which is what's shown on the upper arm up there, the leg, whatever they're wrapping right there. They've put the silver gauze down on it, and then they just put loose dry gauze over it. So that leg down there at the bottom has been coated with the silver sulfidine, and then had gauzes put on top of it, and then it will be wrapped with a dry Curlex gauze. And then these wounds will seep and weep, and they become fluid filled, and that's why we are changing them frequently to make sure that the antibiotics are fresh and that we are keeping any old exudate or wounds clean. Skin grafts are a necessity with most major burns. If the skin's tissue, if it's too deep to recover on its own, then they will graft skin on top of it. There's a couple of different kinds. The most common is your patient's own skin. And what they do is they take a piece, so you can see they kind of take a, I don't want to call it a vegetable peeler, but it's a vegetable peeler, and take off a top layer of skin. So you're basically creating a first-degree burn there. But you're taking off a layer of skin, and then they put it through a mesher so that it can expand over a larger space. So that picture at the top there, I don't know if I can, let's see if I can make it bigger. Oop, no, I can go back and forth. I don't think it'll let me make it bigger. Oh, there we go. Ooh, yay, here we are. So you can see that this one is the donor site here. So this is where they've pulled, and they basically take something that's very not far along from a vegetable peeler, and they peel off a square or a rectangular piece of skin there, and then they put it through this mesher. And so you can see here that this is basically a piece of that skin there that has now been meshed so that it can expand, and that will form a spot where now it will fill in. Those tissues will graft onto the wound bed, and the wound bed will nurture the skin that exists there, and then you will fill it in with your own skin. So it's called a split thickness skin graft. And the reason it's called split thickness is because it is, let me see if I can make it smaller again. Split thickness skin graft because it's harvested and then it's kind of meshed out so that it expands over a bigger site. It is currently the best practice right now, and again, on a patient with huge amounts of burns that don't have donor sites available, that's a little harder. It does create another partial thickness wound, so again, it's your own skin, so it is the best. What they are advancing now is cultured epitheliografts, which is the own skin is actually physically grown in lab, and then they can It's your own skin. It's just lab grown, and it just takes a lot of time and expense, but it is a permanent wound covering. The other two kinds of grafts are cadaver skin from a tissue bank. Because it is cadaver skin and because it's not your own skin, you will reject it after time, but it makes a temporary covering so that you have a temporary graft while it tries to heal up from underneath. And then there's also xenografts, which are from another animal. So allograft or homograft means it's coming from something similar to yourself. Autograft means it's coming from yourself, so it's your own skin. Cultured skin is usually your own skin. Allograft, homograft is coming from another human, but like I said, it's usually rejected. And xenografts are from another animal. They used to be porcine, but now they use tilapia skin. So they will use the skin of tilapia and cover wounds with these grafts, and it allows healing from the underside, but it gives you a protective coating. And they're finding that some of that skin grafts are better than just covering it with antibiotic dressings. They're still covered with antibiotic impregnated dressings while they're healing to prevent infection, but skin grafting does allow, for a actual skin surface. Allografts and xenografts are a temporary covering. Only really your own skin grafts or cultured grafts are going to work to create real skin there. And then the rehabilitation phase, the important part of rehabilitation phase is preventing scarring and contractures. This will involve multiple skin grafts. Most major burn patients have multiple skin grafting. It's not just done once, it's done numerous times over many surgeries. We do want to prevent scarring and contractures in a major burn, especially burns over joints, hands. We want to prevent as the skin heals and regrows and you've got all these grafts, you want to make sure that we do not have scarring and contractures are scarring to the point that the joint or limbs are immobile. So a lot of physical therapy, occupational therapy, huge with burns, and you want to use splints and compression garments. What will happen is if you leave everything splinted for a long time and do not use it, then scar tissue will form, and then when you try to move, everything breaks and bleeds. And becomes a bloody mess. So we want to keep these patients moving. This is why we don't just sedate you until your skin all heals back, because it will heal back in one position, and as soon as you go to bend your arm, it's going to crack and it's going to bleed and everything's going to break open again. So as the patient is healing from burns, they will be undergoing multiple physical occupational therapy. Even a fully burned, 90% burned patient will be doing PT and OT within a couple of days of their burn. And then as you put skin grafts on, as new skin forms, it's at high risk of scarring and scarring into a place where you're contracted. So splints, compression garments. You can see the man down there doing physical therapy there on his arms, has arm thickness, but he's wearing his compression garments, which reduce the amount of scarring going on. So really physical therapy and prevention of scarring and contractures are our big takeaways for the rehab phase. So now you've learned more than you've ever wanted to know about burns. If you have questions, concerns, let me know.